Thank you. Thank you very much. And the next, we'll carry on with diagnosis. And the next lecture will be given by Dr. Ashish Kumar. And his topic for today will be conventional serum biomarkers in HCC, the diagnostic and prognostic significance. Everybody knows Dr. Ashish. He's a senior consultant and professor at Sir Gangaram Hospital. And Dr. Ashish, the floor, please start.
Thank you, Dr. Pankaj. Is my slide visible and am I audible?
Yes, your slides are visible.
Okay. So first of all, I would like to thank Dr. Ajay, Dr. Sunil, and Dr. P. N. Rao for giving me an opportunity to speak on this important meeting. So my topic is conventional serum biomarkers in HCC, its diagnostic and prognostic significance. I would briefly touch upon the history of serum biomarkers for hepatocellular carcinoma. So it was in the year 1956 when Bergstrand et al. Published a study where they analyzed the fetal blood and compared it with the adult blood. And they found that in the fetal blood, there's an extra protein in the range of between albumin and alpha globulin. And so they named it, it was probably a new protein that is secreted only in the fetus, but not in the adult blood. And so they called it alpha-fetoprotein. So this alpha-fetoprotein in the fetus is a 70 kilodalton glycoprotein. And in fetus, it may have same role as the albumin. However, its exact biological function during the embryonic development was not fully known. And soon after the birth, the alpha-fetoprotein levels rapidly declined. Then subsequently in 1963, two scientists from Russia, Moscow, they found that there's a protein which is found specifically in the rat hepatomas as well as in some human hepatocellular carcinomas. And this, they found that this is the same protein which was initially discovered by Bergstrand in the fetus. So from then on, it was found that this alpha-fetoprotein, which was present in the fetal blood, is now also secreted by some of the patients of hepatocellular carcinoma from their tumors. So the alpha-fetoprotein levels in the blood are high in pregnant women because it is being secreted by the fetus. Then it declines as soon as the childbirth occurs. And then it rises again only if there's a hepatocellular carcinoma or if there's some malignancy or some other benign conditions also. So this is the normal and this is the abnormal. But the role of alpha-fetoprotein during embryonic development as well as in the carcinogenesis, along with its mechanism and its function, is still not fully elucidated. Then in 1970s onwards, alpha-fetoprotein started being used as a serologic test for HCC. And this is a big landmark study published in Cancer Journal in 1970, where 813 patients of HCC were examined and their sera was investigated. And it was found that many of these, at least 65% of these patients had raised alpha-fetoprotein. But in spite of the finding that alpha-fetoprotein is raised in malignant conditions, there are certain benign conditions as well where the alpha-fetoprotein was found to be raised, especially in cirrhosis or chronic hepatitis. So are both the AFPs same? So subsequently in 1989, affinity chromatography was used to separate the isoforms of alpha-fetoprotein. And for this affinity chromatography, a carbohydrate binding protein, which is derived from the commonly used lentil, was used, that is lens culinaris agglutinin. And then three forms of alpha-fetoprotein were separated, L1, L2, and L3. And it was found that in HCC patients, it was predominantly L3 fraction, which may be higher than the L1 fraction. While in liver cirrhosis or other benign condition, it is predominantly L1 fraction. So the L3 fraction of the AFP, which is AFP L3 in short, is an isoform of AFP, and it is represented as percentage of the total AFP. And if AFP L3 is more than 10%, then it predicts that the patient has HCC. However, its sensitivity is low. In various studies, even less than 50%, but specificity is very high. But the studies on AFP-L3 have been very limited. Then in 1984, another tumor marker was discovered. It was called as Carboxy Prothrombin or abnormal prothrombin. And in a landmark study published in NEJM in 1984, in about 76 patients, they found that in many of these patients, biopsy confirmed HCC, this abnormal prothrombin was found. So this abnormal prothrombin or des-gamma carboxy prothrombin is also known as prothrombin induced by vitamin K absence 2. It is an abnormal form of prothrombin and it increases in HCC because HCC cells have an acquired defect of carboxylation of the prothrombin. So these HCC cells start releasing the prothrombin, which is abnormal. But PIVKA-II may also be elevated and with vitamin K deficiency, because again, with vitamin K deficiency, same carboxylation would not be possible. And so this released prothrombin will be abnormal. And also in certain antithrombotic therapies such as warfarin. Now, but these three biomarkers, AFP, DCP, and AFP are they don't go hand in hand. There are certain patients in which AFP will be elevated. There are certain patients in which DCP will be elevated, and certain patients there will be AFP-L3 will be elevated, and there a group of patients where there will be no elevation. So what is the current use of these serum biomarkers for HCC? The role of biomarkers in a life cycle of a hepatocellular carcinoma can be a multitude. For example, it can be used in surveillance. So patients of cirrhosis who are undergoing periodic surveillance tests, these biomarkers can be utilized. It can be used in diagnosis. So a patient who comes with liver SOL and is being tested to determine whether this SOL is HCC or something else. Then it can be used in prognosis prediction. So these patients we have diagnosed them as HCC, but they are being staged and we are planning their treatment. So these biomarkers can be useful in these patients. And then response to treatment. So we have diagnosed HCC, and these patients have undergone curative or palliative treatment. So is these biomarkers declining or not? So for response to treatment, it can be used. And also, once that we have given them curative treatment, they have responded. And when we are following these patients to diagnose the recurrence of HCC, these biomarkers may be useful. So I'll come to one by one all three biomarkers. So first, AFP, the use of AFP for surveillance. It is the most widely used biomarker for surveillance, but if it is used alone as a surveillance tool, it has got suboptimal performance. Its sensitivity is about 60% and specificity is around 80%. The low sensitivity is because the concentration of AFP is related to the tumor size. So it would detect only advanced tumor and not the small tumors. So if AFP is used alone, it will miss about 40% of HCC because of low sensitivity. And also it is not very specific because it can be raised in chronic hepatitis B, chronic hepatitis C, cholangiocarcinomas. So if it is raised in these conditions, it will lead to false positive results and will lead to unnecessary tests like triple phase CT and other tests. But combination of ultrasound and AFP is better because it increases in detection rate for HCC. So for use of AFP for surveillance, we should use it in combination with ultrasound. And in a recent meta-analysis published by Dr. Singhal, who will be the next speaker, this meta-analysis of 32 studies comprising about 13,000 patients, it was found that only in 40% of HCCs are detected at an early stage. But if we use ultrasound, the sensitivity of ultrasound is 45% to detect early HCC. But if we add alpha-fetoprotein, then at least 63% of these early HCCs could be detected. So from then on, alpha-fetoprotein is now in recommendation that in combination with the ultrasound, it should be used as a surveillance tool. So what should be the AFP cutoff for the diagnosis of HCCs? So this is another meta-analysis published in last year only. It's a meta-analysis of 59 studies comprising about 11,000 HCC patients and 21,000 controls. It was found that if the AFP is used in the range of 20 to 100, AFP cutoff, then sensitivity is quite low, that is 61%, and specificity is also low, that is 86%. But if we raise the cutoff of AFP to 200, then sensitivity again falls down further, but the specificity raises, that is 98%. And if the AFP cutoff is taken as more than 400, then it is obviously very low sensitivity of about 1/3 of patients, but specificity becomes almost 99%. So as we increase the cutoff, the sensitivity decreases, the specificity increases. So what about the role of AFP in prognosis? So patients who have high AFP have lower survival. So this is a meta-analysis of 61 studies published this year only, where it was found that if the AFP is high, the recurrence-free survival was poorer. The hazard ratio was 1.5, and even overall survival was poorer with the same hazard ratio. So if there's high AFP, so regardless of what treatment you give, the survival will be poorer. What about the patients who are having high AFP and those who are undergoing liver transplantation? Another meta-analysis of 24 studies, and it was found that patients who have AFP more than 50%, the recurrence rate was about 15%, but if the AFP was less than 50, the recurrence rate was in 11%. So more AFP, higher recurrence rate. What about if the AFP is very high, suppose 400? So this is another meta-analysis of 17 studies, where it was found that if the pre-transplant AFP was more than 400, the recurrence rate was for HCC was about 2.69-fold. So in the previous slide, we saw if the AFP is more than 50, the recurrence rate is 15%. But if the AFP is more than 400, the recurrence rate becomes almost 3 times. And so because of these high recurrence rate, the AFP has now has been incorporated into various transplant criteria. For example, Hang-Soo criteria, where AFP cutoff of 400 is taken, AFP model, AFP TDT criteria, and various other criteria. Samson criteria takes an AFP cutoff of 1,000. So it is now incorporated in various transplant criteria. And also after treatment, if the AFP declines, then the response and survival is better. So this is a meta-analysis of 29 studies, and after giving local regional therapy or some curative or therapy, within a period of 1 to 2 months, if there was any reduction of AFP, or if there was 20% reduction or 50% reduction, so if there's any reduction, the survival was better. The hazard ratio was 0.41. So whether it was curative therapy, local regional therapy, systemic therapy, or combined therapy, if once we are given therapy, if the AFP falls down, then these patients have better survival. So the utility of AFP is in surveillance, as we saw, in combination with ultrasound, in diagnosis, as we saw that if the cutoff is increased, it gives a positive diagnosis, and also in prognosis, as well as assessing the response to treatment in hepatic resection, liver transplantation, biologics, and other checkpoint inhibitors. What about PIVKA-II? PIVKA-II and versus AFP, PIVKA-II and serum AFP levels don't go hand in hand. There's no positive or negative correlation between them. These are independent marker. And it is said that PIVKA-II is more specific marker for HCC than AFP, because other liver condition rarely give rise to elevated PIVKA-II, and except for intake of warfarin and other vitamin K deficient therapies. The serum half-life of PIVKA-II is much shorter than AFP. So it will be a better marker for HCC tumor response after giving therapy. And if is also, it correlates with the stage of HCC. So PIVKA-II II versus AFP for HCC diagnosis, another meta-analysis of 31 studies. It was found that AFP had, in this meta-analysis, was found that AFP had a sensitivity of 66%, specificity of 84%, but PIVKA had same sensitivity but a higher specificity. And the area under curve of PIVKA was 0.856 as compared to AFP, which was 0.77. So it is a marginally better specificity than AFP. Then patients undergoing locoregional therapy, again, the DCP or the PIVKA-II levels, those patients who have lower DCP have a better overall survival. For example, those patients who are receiving TACE and they had lower DCP, their survival was better. And those who are having higher DCP levels, for example, those undergoing RFA or ablation, if the DCP levels are higher, then the overall survival was poorer. Again, patients with high DCP have higher HCC recurrence. So patients with a DCP or PIVKA-II levels more than 300 to 400 have a 5-fold high recurrence rate. And because of this, in few of the transplant criteria, again, DCP is also incorporated with a cutoff of 400 or 300, like in Kyoto criteria, Kyonshu criteria, AP levels, and AP 200 levels. What about AFP-L3? The AFP-L3 has got very low sensitivity as compared to both AFP as well as DCP, but very high specificity. In a meta-analysis of 6 studies, the sensitivity was as low as 34%, but specificity was 92%. So what if we combine all these tumor markers? So as I showed that these tumor markers are independent. So in a study which was conducted in 2015, it was found that in about 66% of patients, AFP was elevated, 65% DFP was elevated, and about 43% of patients, AFP-L3 was elevated, and about 159 patients, about 20%, none of these were elevated. So there's another meta-analysis of 6 studies where they have combined AFP and AFP-L3 for diagnosis of HC. And it found that the sensitivity is increased because of combination 71%, and specificity is also increased to 79%. Another meta-analysis of 40 studies where AFP is combined with DCP for diagnosis of HCC. Sensitivity is higher, 80%, specificity is also 80%. Another meta-analysis of 11 studies where all 3 of them have been combined, AFP, AFP-L3, and DCP, and the sensitivity goes up further, 88%, specificity is about 80%. So use of tumor markers in HCC staging, many of the staging systems like BM-JIS staging and GRATEX staging, Ballard scoring, and some other staging have now started using tumor markers, especially AFP, and sometimes DCP as a included them in the staging system. Also, there's one interesting study where they found that if all 3 tumor markers are positive, that means triple positive, then these patients have very poorly differentiated HCC. They have increased chances of microvascular invasion. They have more invasive growth as compared to all triple negative tumor markers patients. So to summarize, all the 3 conventional biomarkers of HCC, that is AFP, DCP, and AFP-L3, have definite role in HCC diagnosis and prognosis. Although AFP have been so much criticized that it has poor role, but its role is established and we cannot go away with it. And individually, each of these biomarkers may not perform optimally, but when combined with each other, either all 3 together or at least 2 of them together, or when combined with other modalities, for example, alpha-fetoprotein with ultrasound, they have increased utility. So these biomarkers are going to stay until we have better biomarkers available, but till now, all 3 of them are going to stay. Thank you for your patient here.